for numerous journals and has served on the editorial boards of major scientific journals in the field of diabetes and metabolism. He has published over 400 articles in the peer-reviewed international journals. And finally, Professor Dr. Stefano Del Prato has been awarded several honors, including the prize of the Italian Society of Diabetology, the honorary professorship at the Cayetano Heredia University in Lima. Thank you so much for your time, Doctor, and welcome to the webinar. The virtual platform is all yours. And now I request Dr. Julio Rosenstock to take up the stage.
Well, thank you very much for the kind introduction, and thank you very much for inviting me to participate in this meeting with my very good friends, Professor FRONZO and Del Prato, and to have the opportunity to put in perspective the role of the Sglt2 inhibitors in preventing and giving some benefit for cardiovascular issues in type 2 diabetes. So what I'm going to do today is to give you an overall update and an overall summary of the cardiovascular outcome trials with Sglt2 inhibitors in type 2 diabetes, and focus specifically in cardiovascular mortality and in the heart failure benefits. Over the years, I've been fortunate and privileged to be involved in many of those trials and the development of these drugs. And I'm going to give you an overall balanced perspective of all the different Sglt2 inhibitors that we have the opportunity to work with. So as we try to focus on cardiovascular benefits, there's no question that we have come a long way with Sglt2 inhibition and cardiovascular benefits. And it is important to have these benefits because the issue and the magnitude of the cardiovascular problem in type 2 diabetes is huge. We know we have very strong epidemiologic evidence where we know from this meta-analysis of 102 prospective studies that clearly people with type 2 diabetes, right from the beginning, they have an increased risk of coronary heart disease is twofold, and some data even threefold. Coronary death is also increased by twofold. Non-fatal MI is quite frequent, and of course also different stroke subtypes. And the issue is that it is increased cardiovascular that take away some years of life that they are lost due to these vascular deaths. As you can see, that is the major reason, both in men or in women that is afflicted by issues of cardiovascular disease. And over the years, we've done very well in terms of the atherosclerotic cardiovascular disease with the use of statins and good control of blood pressure. But one problem that remains very high is hospitalization for heart failure that is still predominant in the United States, in any of your countries in Asia Pacific as well. As you can see there, over the years, it's been coming down, but still heart failure is the most frequent cardiovascular event. And people with with heart failure, they have a very high mortality, up to 50% over 5 years. This is in men, and the same is true in women. So as we focus on the Sglt2 inhibitors, let's look a little bit over a history. And actually, the whole thing started with the apple trees. And the apple trees is where the Sglt2 inhibitors were isolated from the root bark of the apple tree. And this was done by the French chemist in 1835. Subsequently, a German, Joseph Marin, discovered that fluorescein, this Sglt2 and Sglt1 inhibitor, causes glycosuria. And in 2004, only 16 years ago, 17 years ago, there were the synthesis of the first selective inhibitors. And the first human trial just happened 13, 14 years ago. But this fluorescein was important because it was a great research tool for testing the insulin-dependent correction of glucotoxicity. So you just have a massive glycosuria, and then you render the experimental animals normal glycemic. And that's how Professor FRONZO with Luciano Rossetti, this is very famous study published in JCI in 1987, determined that by correcting hyperglycemia with fluorescein normalized the tissue sensitivity to insulin diabetic rats and also improve pancreatic function. So as a research tool, but then as the Sglt2 inhibitors became available and tested, they showed that they were very effective, and the mechanism is quite straightforward. As you know, the Sglt2 is a transporter in the proximal tubule, exchanging sodium and potassium, sodium and glucose or potassium. And when you block this transporter, then the glucose that is filtered there passes there and gets massively excreted, both sodium and glucose, and causes glycosuria, natriuresis, osmotic diuresis, and in an average of 80 grams a day, and varies depends on whether or not the person is hyperglycemic. So all of you are aware, it's available in most of your countries. Obviously, some of your countries have all of them, or some of them with different indications that you're going to be reviewing in each individual countries. But we know that very clearly that the most prevalent use in empagliflozin, canagliflozin, and dapagliflozin, on average, they've been consistently shown an A1C reduction between 0.7 and 0.8%. On average, they have a weight loss of 2 to 3 kilograms. And on average, they have a 3.5 to 5 millimeters of mercury reduction, which is very important. And even diastolic can drop by 2 millimeters of mercury. This is actually very consistent in most of these very good glucose-lowering agents that work by blocking the transporter of SGLT2. So, because of the rules in the United States from 2005, any new medication requires to be confirmed cardiovascular safety, and those are the regulatory required cardiovascular outcome trials. Specifically for the SGLT2 inhibitors, we have the EMPA-REG outcome, CANVAS program, DECLARE TIMI, and VERTIS CVU cardiovascular. And as you all know, there is a plethora of cardiovascular outcome trials that any single new agent for type 2 diabetes need to go through. We have cardiovascular outcome trials for DPP-4 inhibitors. We have cardiovascular outcome trials for GLP-1 receptor agonists. Same is true for SGLT2 inhibitors and even for basal insulin. But what we're going to do is focus on the cardiovascular outcome trials for the SGLT2 inhibitors. In general, the study designs of these trials, as you can see, whether one is for empagliflozin, canagliflozin, dapagliflozin, or ertugliflozin, they are all randomized controlled trials, double-blind versus placebo, added to the standard treatment. And the main inclusion criteria, specifically for EMPA-REG outcome and ertugliflozin cardiovascular outcome trial, they all have to have evidence of a vascular complication, a previous MI, a stroke, etc. Whereas in the CANVAS or DECLARE TIMI, you can have a high-risk cardiovascular events. The population is, you can see, they were in the thousands. The one that is the most, had the highest population, the study was the DECLARE TIMI for 17,000, but in general was anywhere from 4,000 to 7,000. The primary outcome is 3P MACE, which is non-fatal MI, non-fatal stroke, and cardiovascular death. A CANVAS-R was an added study for CANVAS because there was a question that the FDA wanted to look at the progression of albuminuria. But in general, they all look at 3P MACE with secondary outcomes where they looked at the composite of, as we'll discuss later, composite of renal function of 4P MACE that includes unstable angina. And DECLARE TIMI also looked specifically at heart failure and revascularization. So there is clear benefits for the Sglt2 inhibitor. The first one that was reported in 2015 was the EMPA-REG outcome in the New England Journal of Medicine. As you can see that they have a positive beneficial effect for MACE, cardiovascular death, and heart failure. And at that time was a real game changer when it was first reported at the ESD at that year. This was consistently demonstrated with the CANVAS program, where you can see that there were benefits for MACE and heart failure. The dapagliflozin that also had a consistency benefit with heart failure, and etugliflozin also have consistency with heart failure. As you can see, if we're going to summarize in this subsequent slides, just to give you a flavor of what you can accomplish and the consistency of findings, you can see that in the EMPA-REG outcome, the 3P MACE of cardiovascular death, non-fatal MI, and non-fatal stroke was improved or reduced by 14%. As you can see, a heart ratio of 0.86 with a confidence interval, so 95 confidence interval from 0.74 to 0.99. Very important is also have a 38% reduction of cardiovascular death, so strong and so positive that the FDA gave the indication for epagliflozin as a reduction of cardiovascular death. There was a reduction of 35% on the frequency of heart failure. All-cause mortality was also reduced, and the kidney outcomes defined by doubling of the serum creatinine, accompanied by the GFR less than 45 or replacement therapy with dialysis of kidney death, it was reduced by 46%. Then came CANVAS with the canagliflozin. They have also 14% reduction of the 3P MACE. Cardiovascular death was reduced, but didn't quite get significance with an upper confidence interval of 106, crossing the unity. Heart failure was clearly reduced by 33%. All-cause mortality was reduced by 13%, but did not get significance. And the kidney outcomes were clearly reduced by 40%. That was canagliflozin. Dapagliflozin also for the cardiovascular outcomes. As I mentioned, they have the 3P MACE that was reduced by 7%, didn't quite make it for a cardiovascular benefit, crossing the unity of 1.03. But very clearly, the composite of cardiovascular death and heart failure was reduced by 17%, very strong p-value, and the heart failure was also reduced by 27%. They have a primary composite outcome of a sustained reduction of 40% of the EGFR, end-stage kidney disease, or kidney or cardiovascular death. And you can see was reduced by 24% in kidney outcomes, or more specific, including albuminuria, reduced by 47%. What is important with the DECLARE team is that 59% of these people had only cardiovascular risk factors. And as you can see, that there was no interaction between the people who have no statistical interaction between the people who have cardiovascular evidence of atherosclerosis or people with heart failure or multiple risk factors. They all have the same benefit, and the same is true for the kidney outcomes. Putting forward the concept that you can actually not just reduce there, you can actually prevent the development of these cardiovascular events. Vertis was a little bit of disappointment with etugliflozin that was recently reported. Is the one that had the least reduction of the 3P MACE with only 3%, and the upper bond clearly crosses unity with a 1.111, so it's only reached the non-inferiority. Cardiovascular death was reduced by 12%, but not quite get the significance. Cardiovascular death, this cardiovascular death or heart failure, the combined one, did not get the significance. Cardiovascular death was only 8%. Heart failure was consistently reduced at less than 30%, and was statistically significant. And the kidney outcomes did not quite reach significance of 19%. So those are the ones who were regulatory required. But then, based on those findings from the secondary outcome that they show a very strong signal, secondary outcome of cardiovascular outcome trial, that some dedicated studies were designed. Credence with canagliflozin that was just reported, DAPA-CKD for dapagliflozin, and EMPA-KIDNEY that is still ongoing. This is the data from the canagliflozin, and Professor De FRONZO is going to refer in more detail, but just to suffice it to say that the primary outcome of end-stage kidney disease, doubling of the serum creatinine, death for kidney causes of cardiovascular death, was strongly reduced by 30% in those people who have type 2 diabetes with established chronic kidney disease. That's the study population that was specifically designed, study designed and to get the prevention of kidney progression as a primary outcome. Then the secondary outcome that was confirmed with cardiovascular death or heart failure, that is even more double in people with chronic kidney disease. If people with type 2 diabetes have an increased frequency of cardiovascular disease, people with heart failure, people with chronic kidney disease will have even more heart failure and cardiovascular disease, as Professor De FRONZO will be reviewing. 3P MACE was also reduced by 20%, and heart failure was reduced by 39%. With dapagliflozin, the DAPA-CKD, you can appreciate that there was, for a primary outcome, a sustained reduction of more than 50% of eGFR, end-stage kidney disease, renal or cardiovascular death was reduced by 39%. There was also prevention of the progression of the kidney function, prevention of the worsening of renal function, of death from kidney failure was reduced by 44%. Cardiovascular death or heart failure was reduced by 39%, and all-cause mortality was reduced by 31%. So also for heart failure, they were dedicated studies. DAPA heart failure was designed specifically for people with heart failure, whether they have type 2 diabetes or not type 2 diabetes. And the same is true for Emperor Reduce, with empagliflozin was enroll people who have heart failure with or without diabetes. And as you can see, DAPA heart failure was a very robust study in terms of the outcomes. You can appreciate that there was a reduction of 26% of worsening of heart failure or cardiovascular death in people who have established a heart failure. In the previous studies that I show you that were the regulatory required, 17 to 25% have a heart failure to begin with. Here, all of the patients have heart failure and was reduced by 26%. The worsening of the heart failure, cardiovascular death, heart failure or cardiovascular death specifically, it was reduced by 25%. Total heart failure, to cumulative events in cardiovascular death, was also reduced by 25%. The Kansas City symptom score was improved. The composite kidney outcomes was also improved by 39%, and all-cause mortality was also reduced by 17%. So what we can say that the results were generally consistent in pre-specified patient groups, including patients with or without type 2 diabetes, and the rate of adverse events, improvements and reduction were similar. The progression was similar, but was overall reduced by dapagliflozin. In terms of heart failure, with the DAPA heart failure, this is the whole cohort, as you can see, that was reduced by heart failure and cardiovascular mortality by 26%. But as you look at the people with type 2 diabetes at baseline, whether they have it or don't have it, with or without diabetes, you can see that the reduction was consistent there. And so that makes this medication more generalized. Of course, this is approved in some countries. They use it for that with or without diabetes. And in some of your countries may not be approved and will be used off-label until it gets approved. The Emperor Reduce also has a primary outcome, cardiovascular death or heart failure was reduced also by 25%, very closer to the dapagliflozin. The total first and recurrent heart failure events were reduced by 30%, And the progression of the kidney disease by looking at the slope of progression was improved. So people were progressing much more slower with empagliflozin. So this gives you an overall perspective. But if we want to put everything together in the meta-analysis that was conducted by my friend Darren McGuire from Dallas, Texas, you can see that if we looked at MACE as a whole, all the cardiovascular outcome trials that were required for approval, EMPA, CANVAS, DECLARE, and VERTIS, including Credence that they included chronic kidney disease, you can see that the overall the pool estimate it was reduced by 10%. When we looked at MACE, whether they have atherosclerotic cardiovascular disease, you can see that the reduction was 11%. When we look at people without atherosclerotic cardiovascular disease, only with risk factors, didn't quite get the benefit crossing the unity with a reduction of 6%. When we looked at cardiovascular mortality, you can see that the overall the reduction was 15%. As you can see, the pool estimate, the one that showed the strongest effect that drives the meta-analysis, the EMPA-REC outcome, as you can see that with a reduction of 38%. When we looked at heart failure hospitalizations, it's very consistent with all the Sglt2 inhibitors. You can appreciate that was reduced by 32%. When he looked at those people by presence of atherosclerotic cardiovascular disease or no atherosclerotic cardiovascular disease, the effect is very strong in the hospitalization for heart failure, a reduction of 30%. But in people who don't have atherosclerotic cardiovascular disease, only with risk factors, still you have a 27%, which is very important in terms of primary prevention. In terms of those dedicated studies for heart failure that included people who have heart failure to begin with or without diabetes, you can see that very clear that the reduction of first hospitalization for heart failure cardiovascular death was reduced by 26%. When they looked at cardiovascular death, then you can differentiate there that DAPA heart failure does have a reduction of 18%, but the Emperor Reduced didn't quite get the reduction of cardiovascular death. So to summarize and conclude, we can say that the ACE cardiovascular outcome trial demonstrated the beneficial effects of Sglt2 inhibitors in type 2 diabetes. In all the trials consistently, as I said before, a reduction of A1C levels, body weight, and blood pressure that is similar in most of them. The cardiovascular events, heart failure, cardiovascular mortality, and all-cause mortality, they show benefits in kidney disease progression. Clearly, all these trials show the benefits in patients with heart failure and chronic kidney disease with and without type 2 diabetes, and the use has been expanded beyond the type 2 diabetes in cardiology and nephrology. So we now really need to have a holistic approach to diabetes care so we can address the cardiovascular, renal, and metabolic aspects in terms of getting good glucose control. But obviously, we have ACE inhibitors, ARBs, statins, and of course, Sglt2 inhibitors should be part of the whole package that people with type 2 diabetes need to take. So that's why the guidelines, and as Professor Del Prato will be reviewing, recommend the early use of Sglt2 inhibitors for treatment of patients with type 2 diabetes due to their cardiorenal metabolic benefits. And in my book, anybody who gets discovered with type 2 diabetes presumably had diabetes for several years. That patient has already, right from the beginning, an increased cardiovascular risk. That patient probably is overweight, has dyslipidemia, and mildly elevated blood pressure. So it is my thought that these people need to be started with an Sglt2 inhibitor right from the beginning, in combination of dual therapy with metformin, because we know it's been there for 50 years. So all this controversy whether which one to start first, well, it should not be. We need to start with two, the dual therapy, including an Sglt2 inhibitor with metformin, and of course now I'm joining the group with Professor De FRONZO that he's been leading that for many years, that we need to have more aggressive right from the beginning with multiple therapy. I go for dual therapy, he goes for triple therapy. One of these days, I'm going to catch up with him. So thank you very much for your attention, and I leave the podium to my good friend, Professor Ralph DeFronzo. Thank you.
Thank you so much, Doctor, for your fabulous speech. I now welcome Professor DeFronzo to present his session.
Seems like Professor DeFronzo has logged out. I think he's having some connectivity issue. Professor Del Prato, would you like starting your presentation?
Yeah, I mean, no problem at all if I can, so we can avoid any further delay. So let me just, share my screen.
Thank you, Professor.
So what's going on? Hold on, just because there is some problem here. Can you see the screen?
Yes, Professor.
Okay, so let me put that in presentation. And again, let me first of all join my good friend Professor Julio Rosenstock in thanking Medisage for this invitation. It is a great honor to be connected with so many people, though virtually, and even more to have the opportunity to discuss what is becoming a very important topic in the field of diabetes, in particular type 2 diabetes, like the Sglt2 inhibitors and the position of the Sglt2 inhibitors in the treatment for people with type 2 diabetes, with such good friends and much esteemed colleagues like, as I said, Professor Rosenstock and Professor Ralph DeFronzo. Now, Professor Rosenstock has provided you with a very nice overview of what are the most current results in terms of the CVOTs and renal trials that are being performed with the SGLT2 inhibitors, and really has set the stage of what could be the new step forward in the guidelines and indeed the treatment and the algorithm of the treatment for people with type 2 diabetes. I'm probably going to repeat some of the information that Professor Rosenstock and later on Professor DeFronzo will be providing you with. But what I will try to do is try to summarize this all together
I
and
can
try
see
to
he's
put that
talking now. I've got him.
and in the perspective of the treatment of type 2 diabetes. So first of all, these are my duality of interest, and also before I move on, and I think that this what I'm going to show you is also valid for what has been presented already for Professor Rosenstock and will be presented also by Professor Ralph DeFronzo, is that the lectures that you're going to see and you are going to listen express the personal opinion of the presenters and may not always represent the interpretation of drugs manufacturers. Also remember that some of the reported indication may not apply to all world regions. So you are encouraged to refer to local approved indication for the use of the drugs that we've been discussing. Now, Professor Rosenstock has been pointing out to what has been the result of the cardiovascular outcome trial, and Professor DeFronzo will speak more about the impact on the kidney of this treatment. But if you really want to look at what has been the evolution of the positioning of the SGLT2 in the current treatment algorithm for the type 2 diabetes, I think that you also need to really go back to what has been the recommendation that were valid just not very long time ago. Because you may remember very well, and this is just an example of a very well recognized and used in all around the world recommendation for the treatment of type 2 diabetes, that something like 10 years ago, the main goal for the treatment that we had for our people with type 2 diabetes really was to try to achieve and maintain, even by intensifying treatment, a very good glycemic control. And we have been living with this magic number of an A1C of 7%, that it was really based on instrumental, very important, but yet to some extent old study, such as the UK PDS. And you may see how in the 2006 the goal was set for achieving an A1C of 7. There was an algorithm put there, although it was an algorithm that was really based on a very scanty number of anti-hyperglycemic agents. It was metformin, it was sulfonylureas, there was some the glitazones, and it was insulin. Now, there was none of the new drugs that we've been using more recently. These new drugs loomed up a couple of years later, and you can see here in the 2009 what has been the recommendation for that expert consensus. And what was recommended there was the differential use of different drugs, and also the introduction of new drugs. In this case, you can see here the GLP-1 receptor agonists are mentioned for the first time, although you can also appreciate how these novel drugs, GLP-1 for instance here, were put in this tier 2 of less validated therapy. You can see that here there was not specific indication for what is the target for the treatment, although if you read carefully what has been written in the consensus, the target still remain A1C. In other words, all the work, all the effort, all the intensification of the treatment had to be conceived and had to be translated into the practical treatment in order to achieve glycemic control. And in this environment, it was when the SGLT2 entered the pharmacopoeia for the treatment of diabetes. Now, let me remind you that the SGLT2, as Professor Rosenstock already presented and reminded to you, have been introduced as glucose-lowering agents. Although this glucose-lowering capacity was based on a very specific mechanism that have nothing to do with the stimulation of insulin secretion or direct impact on insulin sensitivity, the two major factors accounting for the chronic hyperglycemia in type 2 diabetes. And the proposal was very simple, and I would also like to join Professor Rosenstock in commending the important role of Ralph DeFronzo with the fluorescein studies, showing that it was possible indeed to reduce glucose control simply by blocking the reabsorption of the glucose that is mainly accounted for by SGLT2 at the level of the proximal tubule, and because of that, allowing more glucose to be excreted and more glucose proportional to the concentration of the glucose in blood. So the final result is that through the inhibition of the SGLT2, you do lose more glucose. Losing more glucose also means losing calories, and losing glucose also is associated with an osmotic effect that also allow to lose and to increase the fluid excretion. And because of that, the final result, the clinical result, is improvement in glycemic control. You lose glucose, and to some extent you manage to have a better control on the body weight because you're losing calories, and this also may help a little bit through fluid elimination also to have a favorable impact in terms of the blood pressure. And there is no doubt, as I mentioned, that the SGLT2 at the time they were introduced into the pharmacopoeia for the treatment of diabetes were presented as glucose-lowering agents. And in fact, a very careful clinical development was established, and you can see here what is the overall effect in terms of reduction of A1C with the low dose of an SGLT2 inhibitor. You can achieve in these people with monotherapy a reduction in A1C between 0.6 and 0.8% in average, but even more, because the mechanism of action in terms of glucose lowering efficacy is independent of the typical mechanisms associated with the pathogenesis of type 2 diabetes. This effect is retained in any other condition or any other form of treatment for hyperglycemia type 2 diabetes, as is shown here, because the same degree of A1C was achieved when a higher dose of monotherapy of SGLT2 were used, or when they used as an add-on on top of metformin, on top of DPP-4, on top of sulfonylureas, on top of TZDs, and even on top of insulin, with or without the presence of oral anti-diabetic agents. And we can appreciate that that specific mechanism, that as I'm again saying, as I said, is independent of the classical activation of insulin secretion, of insulin sensitivity, is retained in any of these conditions here. So SGLT2 has been proposed as a potential way to improve glucose control in people in any stage of their condition. And that's where we were staying at that point. And that was what this drug were being also proposed for the treatment of the diabetes. Till a very important moment. And that important moment has been already reminded to you by Professor Rosenstock. And that time was actually September 2015, when at the EASD were presented the result of the first cardiovascular outcome with the use of an SGLT2 inhibitor, namely empagliflozin. And what really was received with a round of applause was a fantastic result that for the first time provided the opportunity or provided the information that this was indeed possible to reduce the risk of cardiovascular disease in people with type 2 diabetes. So you may remember very well, because this data have been becoming sort of classical data in the history of diabetes treatment, that the EMPA-REG outcome showed that in terms of the 3-point MACE, cardiovascular mortality, non-fatal myocardial infarction, non-fatal stroke, there was a significant reduction of 14% of the relative risk. But even more, there was an incredible, unexpected 38% reduction in the risk, the relative risk of cardiovascular mortality, that was coupled with a phenomenal 32% risk reduction of death for any cause. And just to revitalize or to resuscitate something that was known but not very much considered till this time, was the fact that this treatment also was associated with a 35% reduction in the relative risk of hospitalization for heart failure. Now, as you can imagine, these results were fantastic. Someone, may also was thinking that, they were too good to hold true in the subsequent trial, but this indeed was not the case, because all the subsequent trials that have been performed with the different SGLT2 inhibitors, and Professor Rosenstock already took you through all of them, confirm overall what is a beneficial effect of the SGLT2 inhibitor in terms of the 3-point MACE. And you can see here the meta-analysis, the same meta-analysis that has been used by Julio, produced and made by Dr. McGuire, and showing that overall the impact of SGLT2 inhibition in people with type 2 diabetes, with a different degree of cardiovascular risk, because you go from people with a 100% prior cardiovascular event to people with a much lower cardiovascular risk, like for instance in the CLARE, that was associated with a significant 10% relative risk reduction for MACE. And even more, as I mentioned, although with a little bit more of disparity and differences from a trial to trial, overall, a 15 significant reduction in terms of the relative risk for cardiovascular mortality. I already mentioned that something that really struck at the time of the presentation of EMPA-REG, so on top of whatever has been already presented, really was the impact on heart failure. And let me just remind you again that the heart failure was there. We were very well aware of the risk for people with type 2 diabetes with heart failure, but we had no really significant ways to impact on the risk of heart failure in this population. And this was shown very clearly that the SGLT2 in EMPA-REG, in CANVAS, in DECLARE, in VERTIS, shown in this slide, all of them were very systematically showing a significant improvement in the reduction of the risk for heart failure with this trial. And again, when you turn to the meta-analysis, from a size point of view, the relative risk reduction is even much, much greater than the one that's been reported in terms of MACE, because you may remember the MACE reduction was about 10%, and here we are speaking about a 32% reduction in the relative risk for first hospitalization for heart failure. Now, this effect has been proven in this cardiovascular outcome trial. The question was to which extent this result could also be translated into the daily practice. In other words, to which extent a similar result could be obtained in the real world setting. And actually, a number of studies have been performed looking at what is the impact of use of SGLT2 inhibition in the real world, in our diabetes clinic, in our daily patients. I'm just reporting you one, for the sake of the time, of these studies. This is the MPRISE study, where people have been selected among those using sitagliptin, the DPP4, which we know is neutral with respect to their heart failure, and compared with empagliflozin by a propensity score, just to make sure that the two populations were comparable. And what you can see here, although to some extent absolute term difference, there is this very strong signal that SGLT2 inhibition, empagliflozin, was even better in terms of reducing the relative risk for hospitalization for heart failure. And in this case, the relative risk reduction can be calculated in the range of 50%, which is not that far away from the one that has been reported in cardiovascular outcome trials. Now, the big question that has been also a matter of a long discussion is, where is all this benefit coming from? So what is the mechanism of accounting for that? Now, this could be quite a long story to go through. So I've summarized in this slide, taking advantage of a paper that Professor De Fronzo has published a couple of years ago, all the different potential mechanisms that have been claimed that could provide the beneficial effect of the SGLT2 inhibition. And you can see that on the left-hand side, you have the so-called metabolic effect, and on the right-hand side, the non-metabolic effect. Among the metabolic effect, the first one that comes to our mind, of course, is what is the impact of the improvement of glycemic control. Well, do remember that most of these studies were equipoise studies. That is, they were not really trying to strive for reducing to a further extent glucose control in people under active treatment. Actually, the purpose of the study was to try to avoid as much as possible differences in glycemic control. And in fact, all of these analyses, these results have been analyzed in terms of the effect of the glucose control. Glucose really turned out not to be a major player in this benefit brought about by the use of the Sglt2 inhibitors, which brought up another hypothesis. That is, if this is not going to be true glucose control, does that mean that the Sglt2 inhibition can also convey benefit in people without hyperglycemia? In order to explore to a better extent what is the property of the Sglt2 inhibition in people with heart failure, as Professor Rosenstock already mentioned to you, specific studies have been designed. Like, for instance, DAPA-HF, looking at what was the effect of the dapagliflozin versus placebo in a composite endpoint of cardiovascular death, hospitalization for heart failure, or urgent hospitalization for heart failure. And you can see here that in the overall population that has been included in this study, there was a 26% relative risk reduction. But even more importantly, being cognizant of the point that I was making before, that some of these effects may not necessarily be mediated through the reduction in glucose, this population here was enriched with the people with and people without diabetes. And now you can see that the effect that has been exerted by dapagliflozin, SGLT2 inhibition, was totally comparable in people with and without diabetes. And even more, when this study was also repeated to some extent, and a new trial was provided by using this case empagliflozin in a population very much similar to the one that had been recruited in the DAPA-HF. The result that had been obtained are very much superimposable. It was 26% overall reduction in the DAPA-HF. It is 25% reduction here in the emperor reduced. Reduced because the people that have been included in these studies are people with a reduced ejection fraction. And again, in this study too, population was enriched with people with and without diabetes, and again showing no difference. So the SGLT2 inhibition may bring about a benefit also for people without diabetes. There is another important effect of the SGLT2 inhibition. Professor Rosner already alluded to, and Professor De Fronzo will be expanding this, and this was the repeated findings in terms of positive effect on kidney-related outcomes. You can see here again the meta-analysis, including 5 trials designed to look at the effect of the SGLT2 inhibitors on kidney outcomes. And you can see here again, there's a significant, again, 38% reduction in the relative risk for the progression of complication or progression of kidney failure. Now, also, one thing that's important to consider here, that the vast majority of this study had the kidney result outcome as a secondary item. However, as has been already shown to you, there have been also trials that have been performed directly in people with impaired kidney function to start with. And even more, studies have been performed to show what is the effect in people with kidney disease associated with diabetes and non-diabetes. One important point that I'd really like to make here is that the beneficial effect of the SGLT2 inhibition seems to be independent of what is the starting point of kidney function. You can see here in this meta-analysis again, including 3 SGLT2 cardiovascular outcome trial, the effect in terms of reducing the composite endpoint of renal worsening, end-stage renal disease or renal death in people at the beginning, at entry into the trial with a GFR lower than 60 ml, in people with moderate impairment in kidney function with GFR between 60 and 90, and those with a perfectly normal kidney function as indicated by a GFR higher than 90 ml. And you can appreciate that irrespective of what is the starting point, there is always a significant impact in terms of reducing the risk for progression of this kidney insufficiency and kidney failure. Now, even here, the effect of the SGLT2 may not necessarily be mediated by the effect on blood glucose. And in fact, in DAPA-CKD, the population was enriched with people with and without diabetes, although they were similar in terms of the impairment in the kidney function they started off with. And you can see the overall result, even in this trial here, confirming the positive impact in a specific kidney impaired population in terms of all the outcome associated with renal failure. And even more, when you do consider those with and without diabetes, you can see the same kind of effect. So supporting again what has been a feature of the SGLT2 inhibition in terms of improvement in kidney function, in terms of reducing the risk associated with heart failure, and to maybe a lesser extent in terms of what is the overall cardiovascular risk. And all this has now been translated into being part of the current guidelines. I mentioned before that I started off with the ADA-ESD consensus, and I mentioned to you that at that time, really the target was glucose control. Now, you know very well what has been happening with the most recent version of the ADA-ESD consensus report. And the suggestion was that it's compelling to ascertain to which extent a person with diabetes is characterized by predominant atherosclerotic cardiovascular disease, because that condition may may favor use of specific drugs, for instance, GLP-1 receptor agonists, which may have a more anti-atherogenic effect. But for people who are characterized by heart failure or chronic kidney disease, and in particular for those with a reduced ejection fraction, and for these people with moderate or reduced kidney function, there is the recommendation or to consider the use of an SGLT2 inhibitor. And Professor Rosenstock already mentioned to you all this discussion about metformin or not metformin that has been really triggered by the EASC, the European Society guidelines, when they mention, all right, if you have someone on metformin, but there is a risk for cardiovascular disease, consider using drugs that are associated with a benefit. But even more, they made the jump and saying, if you have a person with newly diabetes, what is important is to really see whether there is a higher risk for cardiovascular disease. And in that case, you should really consider using drugs like the SGLT2 inhibitors, for instance, that could exert a significant impact in terms of protecting these individuals. Which, to me, as a diabetologist, after 40 years of practicing diabetes therapy and spending my work in type 2 diabetes, generates a little bit of an issue. And the issue is, what is nowadays the real target for the treatment of type 2 diabetes? Is that A1C, glycemic control, or is the organ damage? What should I pay more attention? Is considering the effect that is glucose independent of SGLT2 inhibition, for instance, or is the importance to maintaining good glycemic control? Now, I believe personally that this is a little bit of a semantic discussion, because I think that these two concepts here can be easily reconciled. Let me give you an example, give you my personal view. Let me propose to you that tomorrow morning you are going to see in the office, tomorrow morning maybe it's Saturday, let's say on Monday, okay, you're going to see a patient. And that patient is a newly diagnosed type 2 diabetic individuals with a short duration of diabetes, young. And of course, he has, fortunately enough, no macrovascular complication. What would we like to do for that person? I personally would like to suggest that we would like to go into select treatment that may improve glycemic control without exposing them to the risk of hypoglycemia or maybe change in the body weight. Because if we can achieve good glycemic control without side effects, this may also result in improved adherence and maybe reduce clinical inertia. And the combination of the two may result in long-term glycemic control. And long-term glycemic control is still key in reducing the risk of microvascular complication. And if I do really want to achieve good and sustained glycemic control, maybe also should I consider a combination therapy to start with, because there are now potential for combining treatments that are free of side effects or free of hypoglycemia and an effect on the body weight. And because of that, you can then expect to have a reduced risk of microvascular complication that may also translate in the long term also in a reduction in the risk of cardiovascular events. And let me just remind you what is the link between microvascular complication and macrovascular complication, and try to explain to you why I'm really trying to convey the message that is important, particularly at the start of the disease, to provide people with a sustained glycemic control, and because that can be key in reducing vascular in general disease. You know this is the anatomy of the epicardial coronary vessel, and we are very interested in preserving the integrity of this vessel. The clotting, the atherosclerotic process of one of these vessel is associated with tremendous outcome, myocardial infarction, and so on and so forth. But we also need to remember that the epicardial fat are very important because they are supplying an incredible network of microcirculation. And that microvessel, like the microvessel in the eye, like the microvessel in the kidney, can be diseased by chronic hyperglycemia. And by the way, a disease of the microvessel of the heart may be at the basis, at least, of some form of heart failure. So protecting the microvessel may be important also to protect the integrity and the health of the entire organ. And just to support this hypothesis, let me give you another piece of information. These are data that have been generated in the UK in a very large population, close to 50,000 people, where the impact of traditional cardiovascular risk factors like glycemic control, blood pressure, LDL cholesterol have been evaluated in terms of what is the primary outcome: cardiovascular risk, cardiovascular mortality. And you can see here 4 columns. Each one of these 4 columns are different permutation of how much these traditional risk factors are under control. In this column here, you have people with a good A1C, good blood pressure, good LDL cholesterol. In the people in this column down here in the far right hand, you have the people with are not under control for glucose, for blood pressure, and for cholesterol. You can see there is a progressive increase in the risk for the primary outcome. But look at what happened. If you, on top of this, you also put the presence, or take into consideration the presence of 1 or 2 or 3 microvascular complications. Now you can see how the effect of the traditional cardiovascular factor are amplified, are magnified to a very much extent. So suggesting that maybe protecting and reducing the risk of microvascular complication can also help in reducing the impact of other components of the risk for cardiovascular disease. So if we go back to our patients, so we can consider, of course, that it's important for that person with a newly diagnosed diabetes to achieve good glycemic control. However, in considering the combination, we now also could consider combining drugs that may have ancillary properties, that have properties that goes beyond the effect on the glucose control. Like, for instance, the Sglt2 inhibitors in terms of the CKD and the progression of the renal disease. And remember that because of the reduced risk of a CKD, we are impacting over very powerful cardiovascular risk factors, which is impaired kidney function. And even more, because of the effect of the SGLT2, you can also expect to provide some benefits in terms of reducing the risk for development of heart failure. Then on the second day, you may be encountering another person with type 2 diabetes, but that person may be a person who already has impaired kidney function. And for that person, for that patient, we have now a solution, or we have a good suggestion that SGLT2 inhibition may help in reducing the progression of the CKD, but also may reduce the high cardiovascular risk that already characterize these individuals. And finally, your third patient may be, for instance, a patient in its advanced stage of the disease, a person who already has a history of cardiovascular disease. And in that case, what the guidelines recommend is that we do distinguish between those with a preeminent atherosclerotic cardiovascular disease, and then we have a number of options that we can take into consideration, versus those with a prevalent heart failure. And in those individuals now, we have evidence coming from a randomized clinical trial suggesting that SGLT2 may provide them with a significant benefit. So if we go back to the title of my slide, and that was, what is the role for the SGLT2 inhibitors in type 2 diabetes? And I would like to propose to you that the role for these drugs, particularly that started early on, is to allow people to come to the need or the help of the cardiologist alive. So we really want to keep our patient in a better health, and to be able to work together with our colleagues and fellow nephrologists and cardiologists in order to improve the life expectancy and the life quality of the people with type 2 diabetes. And with that, I'll stop here, and I will hand it over to Ralph De Fronzo. Thank you.
Okay, thank you, Stefano. The power is back on. I have to apologize. We were dealing with major power failure here in Texas. So hopefully we're back on and this will work. Now, I'm going to need some help getting my slides up. So I guess I should go to share screen. Is that correct?
Yes.
Okay. Now, in the desktop click on desktop in the upper left,
Yes,
and then share in the bottom right.
correct.
Okay. And then what at this point?
PowerPoint at the bottom.
PowerPoint at the bottom. And then let's see if we can get this slide deck up.
Double click.
I see the slide deck. We're spinning around. Okay. Then go what? To slideshow?
Yes, from the start.
Slideshow. Play from the start. Oh my God, a miracle has happened.
Very impressive, De Fronzo. That's very impressive.
I'm even surprised myself, Julio. Now will it move? Oh my God, it moves. Okay, so with all of these disasters and some cheering on for Professor Rosenstock, I guess we're ready to go. And my focus in the next 20 to 25 minutes is going to be on the kidney. You've already gained some insights about the important role of the Sglt2 inhibitors from the first two presentations. And what I'm going to try to do is expand this and give you a somewhat different sort of feeling about what causes diabetic kidney disease and then how we might go about treating it. So for those of you who are out there taking care of diabetic patients, I know that you know that diabetic kidney disease is a big problem. If you look, you can see here that we've lost over the last decade or so a large number of the years of life, some 90%, due to diabetic kidney disease, compared to a 60% increase in the years of life lost to diabetes. So what is this saying? This is saying that yes, if you have diabetes, is a bad disease, your life expectancy is shortened. But now, if you're diabetic and you develop kidney disease on top of it, then your life expectancy is shortened even more dramatically. Let's see what's happening here. Okay. Now, we now recognize that in the United States and also throughout the world, that diabetic nephropathy is the leading cause of end-stage renal failure, and over half of patients who are entering dialysis units or renal transplant programs have diabetes as the cause of the renal disease, and the treatment of this disease is very, very expensive. You can see in the United States, $36 billion per year. And in your country, in India, and elsewhere in the world, it is equally expensive. So it makes sense to me to try to prevent people from ending up into dialysis programs. That would be a much, much more cost-effective approach. But unfortunately, unlike the prevalence of retinopathy, MI, and stroke, the prevalence of end-stage kidney disease, secondary diabetes, really has not gone down. So this is a very nice slide by Greg Aller. And in yellow, you can see acute myocardial infarction as we go from 1990 to 2000 to 2010 has gone down dramatically. In red, stroke's gone down, amputation's gone down, and end-stage renal disease completely flat. So these are the number of events per 10,000 people in the population. And so although we've made a lot of headway in terms of the cardiovascular complications, we really have not decreased the prevalence of end-stage kidney disease. Now, when you see a newly diagnosed patient with type 2 diabetes, even if they're asymptomatic, you can expect that 2/3 of them have well-established cardiovascular disease. But what's even more disturbing is that about 15 to 20% of them, they're going to have clinically manifest cardiovascular disease. Again, very similar to what Professor Rosenstock pointed out to you in her first presentation. But I'm going to repoint it out, you'll see, for another reason. If you look at mortality in people with type 2 diabetes, it's mostly due to cardiovascular disease. The cardiovascular disease becomes manifest some 15 years earlier in diabetics than it does in non-diabetics. Julio pointed out to you that heart failure, now that our diabetic patients are living longer, is a big problem. But now here's the real killer. Even though cardiovascular disease is increased in the diabetic population in general, if you look at the people with diabetes and chronic kidney disease, what we now have is a threefold greater increase in cardiovascular mortality. So cardiovascular disease, cardiovascular mortality, and diabetic kidney disease go hand in hand. And this, I think, this slide by Go et al. In the New England Journal of Medicine, although it's some 20 years old now, it makes the point very clearly. So they looked at a very large population in a healthcare system of over a million individuals, and they stratified people, and they're both diabetic and non-diabetic in this analysis. They stratified people with a GFR above 60, the first small yellow bar, going all the way to the right to a GFR less than 15. And you can see the number of atherosclerotic cardiovascular events per 100 patient years. If your GFR is greater than 60, goes from 2 to, if it's less than 15, to 36. So this shows you the incredible impact that kidney disease has on increasing the incidence of atherosclerotic cardiovascular complications. And I'm later in my presentation going to come back and repeat this slide for emphasis. So in this analysis, there were both diabetics and non-diabetics. So it didn't make any difference who developed kidney disease, whether you're diabetic or not. You're still going to have a markedly increased risk of cardiovascular disease. Well, what have we learned about the natural history of diabetic kidney disease? This is an old slide that I put together many, many years ago. And I think it depicts very nicely the pathophysiology and the histologic changes that occur in people with type 2 diabetes. So let's set time 0 as the start of the onset of the kidney disease. These are type 1 diabetic patients. Of course, when they develop their disease, it's usually pretty fulminant. So you know this is the time of onset. You control their glucose and you look at their GFR, it looks pretty good, 150, creatinine's 0.8, B1's 10. But this is not normal. If you were to back up in time, you would see 3 years earlier, the GFR is lower. So what's happened is that we now see that they're hyperfiltering. And the etiology of this hyperfiltration is an increase in intraglomerular pressure. So let's now follow this person, as was done in Denmark, with sequential kidney biopsies over the next 3 years. You see no evidence of proteinuria. The GFR remains high. But now, look what happens in the kidney. You see this black material here. This is the increase in mesangial matrix material, glomerulus sclerosis, and what not shown in here is tubular interstitial disease. So within 3 years, you already are developing significant histologic changes. And now if we follow this person through life, you see there's this long silent period, some 15 years, in which really everything looks okay, because we can't be doing sequential kidney biopsies. Now, all of a sudden, this person presents with proteinuria, albumin excretion greater than 300 milligrams per day. We can now pick it up by the dipstick. We go and look at the GFR, you could see, 90, it's already down. The creatinine's 1. You're following the creatinine, that looks pretty good, right? But now you can already see the GFR is going down. And within a period of 5 years, you have your GRR, and within another 4 years, you're at end-stage renal disease, and you've literally obliterated all of the glomeruli in your kidney. Now, is there anything we can do to pick up the disease earlier? And we can. And everybody, I think, listening in out there is familiar with the concept of microalbuminuria. So this is excretion of small amounts of albumin between 30 to 300 milligrams per day. And you can detect microalbuminuria about 10 years earlier than the onset of overt proteinuria. Now, in type 1 patients, microalbuminuria is a very, very ominous sign for the development of diabetic kidney disease. In type 2s, microalbuminuria really is more of a sign of atherosclerotic cardiovascular disease than it is of ensuing diabetic kidney disease. And we're going to come back to that in a moment. Now, what is the etiology, the pathophysiology underlying this progressive kidney disease? this is related to deranged tubular feedback. This is the most popular hypothesis that's out there. And I would say it's not a hypothesis, it's proven. But what I'm going to show you, this is just one of many factors that contribute to the progressive diabetic kidney disease. So diabetic patients, both type 1 and type 2, are hyperglycemic. So they filter more glucose. So more glucose is now going to get to the Sglt2 transporter in the proximal tubule. And as Professor Rosenstock pointed out to you, that glucose and sodium is going to be reabsorbed there. Now, the problem with that is twofold. Of course, that's going to maintain the hyperglycemia, but from the level of the kidney, there's going to be a decreased delivery of sodium to the macula densa cells of the juxtaglomerulosa apparatus. So the JG apparatus views this as a decrease in the circulating volume, and it's going to generate two signals. The first signal is going to go to the afferent arteriole, that little arteriole that's going into the glomerulus. And it's going to tell the afferent arteriole to vasodilate. It's going to increase the blood flow to the kidney, and this is going to increase the intraglomerular pressure. The second signal is going to go to the efferent arteriole, the little arteriole that's coming out of the glomerulus, and it's going to tell it to vasoconstrict, and this is going to further aggravate the elevated intraglomerular pressure. And now your GFR looks pretty good. It's been restored. It may be even hyperfiltering because of the increased GFR. But on a long-term basis, that increase in GFR is going to lead to renal damage. Now, let's take a look at the glomerulus anatomically. We've talked about it, but now you can see here's the afferent arteriole, here's the efferent arteriole. What controls the blood flow in the afferent arteriole is adenosine. So adenosine is a powerful vasoconstrictor. So in the presence of diabetic kidney disease, formation of adenosine is decreased. So instead of vasoconstriction, now you see vasodilation, increased renal plasma flow to the kidney. At the level of the efferent arteriole, there's increased local angiotensin II production and increased sensitivity to A2. And this further aggravates the increase in intraglomerular pressure. So we have drugs that will reverse these problems. At the level of the afferent arteriole, the Sglt2 inhibitors will increase adenosine, and at the level of the efferent arteriole, we have the ACEs and the ARBs, and we know that you can get additive effects from these two different classes of drugs. So we have two excellent medications that we can use to combat and prevent the progressive kidney disease. However, there's another side to the story other than this renal hyperfiltration and intraglomerular pressure that becomes apparent. When you look at people with type 2 diabetes particularly, you see that there are a number of published studies which have failed to find an association with renal hyperfiltration and diabetic kidney disease. Now, most of the studies that have been carried out and demonstrate hyperfiltration is related to kidney disease have been carried out in type 1 individuals. And these type 1 individuals, of course, are much younger than our type 2 patients, and they have much more reactive renal arterioles, perhaps explaining why they're more susceptible to this renal hyperfiltration and increased intraglomerular pressure. So as I said, hyperfiltration is much more difficult to identify in type 2 patients, in large part because of the older onset with established atherosclerotic changes in the renal arteries. Many years ago, when I was a fellow at the NIH at the Baltimore Aging Institute, we showed that there was a marked age-related decline in eGFR, which of course is going to obscure the hyperfiltration. And when you see a type 2 patient, they've already had their disease for 5 or 10 years before they present to you. So there are already a lot of established changes that have occurred within the kidney. So for all of these reasons, hyperfiltration is less prominent in people with type 2 diabetes. So when I gave the Banting lecture to the American Diabetes Association in 2008, I titled it from the triumvirate to the ominous octet, a new paradigm for the treatment of type 2 diabetes. And of course, that was focusing on treatment of hyperglycemia and the pathophysiology of the disturbance in glucose metabolism. However, we now have an ominous octet for the kidney, where we have multiple factors that we're going to have to deal with. And the implications you'll see are that no one drug is going to control all of these factors. So we've talked already about deranged tubular feedback. But remember, what starts this disease is hyperglycemia. If you don't let the blood glucose in a diabetic go above 6.5, you don't see microvascular complications. You don't see diabetic kidney disease. You don't see retinopathy or neuropathy. We also know that once the kidney disease is established, the most important factor that will accelerate the decline in kidney function is hypertension. So you need to pay meticulous attention to the blood pressure. Systolic less than 120, diastolic less than 80. We also know that from the histology studies that there's tubular hypertrophy. The proximal tubule hypertrophy precedes glomerular hypertrophy. And we now know that there are growth factors that are being released by the proximal tubule that are being signaled to the glomerulus to cause glomerular hypertrophy. And when the glomerulus hypertrophies, the pressure within the glomerulus is proportional to the radius. So this contributes to the increase in intraglomerular pressure. The kidney is also hypoxic. All of that glucose and sodium that's reabsorbed in the proximal tubule, that sodium needs to be pumped out of the proximal tubule. That's done by the sodium potassium ATPase pump. That pump requires energy. It requires oxygen, big oxygen demand. And the increase in renal blood flow is insufficient to meet the increase in oxygen demand. So we have marked hypoxia within the kidney, and this leads to an increase in hypoxia, inducible factor, stimulation of reactive oxygen species, and ER stress leading to glomerular sclerosis and tubular interstitial disease. We also know that there's injury to the podocytes. So the podocytes are those cells that sit on the glomerular base membrane, and with their foot processes, they prevent albumin from leaking in to Bowman's capsule. But now, in a person with diabetic nephropathy, there's injury to the podocytes and the foot processes. Albumin leaks into the glomerulus, and that causes a sclerotic, glomerulosclerotic picture, a very important cause of the progressive nature of diabetic nephropathy. Now, down at the bottom is this concept of obesity and lipotoxicity, which is becoming very, very important, and actually is poorly recognized even by nephrologists. So we now have a disease of glomerular sclerosis that's established with obesity, and it is well recognized. You'll see patients who are obese, they present with nephrotic syndrome, you do a biopsy, and they have a picture in their glomeruli that looks exactly like diabetic nephropathy. There's fat in the mesangial cells, there's fat in the glomerular cells, there's fat in the podocytes, there's fat in the tubular cells. Now, how many diabetic patients do you have that are lean? Almost all of mine are obese. So that means that it's going to be very difficult to dissociate what is the component of lipotoxicity and obesity from the glomerular sclerosis that's associated with diabetes. And then down at the bottom, we have genetics. You know, you can't go back and choose your parents again. And we know that there's strong genetic tendency for diabetic kidney disease to run in families. We've done a lot to try to identify these genes that are associated with diabetic nephropathy, but so far, in my opinion, we've really yet to come up with ones that really are playing a major role here. So now, let's take a look at this ominous octet. And now you see the little stars, the Sglt2 inhibitors. They lower the blood pressure, okay? By blocking the Sglt2 inhibitor, they decrease the oxygen demand. They correct the derangement in tubular-glomerular feedback. They're good, as you heard from our previous presenters, they're good at lowering the glucose. They protect your podocytes, And we showed many years ago, along with Professor Farinini, that they stimulate fatty acid oxidation and they burn fat within cells, and you lose about 2.5 to 3 kilograms during the first 6 months of therapy. So the SGLT2 inhibitors correct 6 of the major problems that are contributing to this ominous octet of diabetic nephropathy. Now, that means if we got 8 problems to deal with, no one drug's going to correct all of these issues. And I've been a big advocate of multiple drugs for lowering the glucose in people with type 2 diabetes. And if you think of other diseases, hypertension, we always use 2, 3, 4 drugs. Cancer, multiple drugs. AIDS, multiple drugs. There really is no disease we just treat with a single drug. In the diabetes field, we are light ages behind how we approach therapy of hyperglycemia. But we should not get stuck in the same rut with diabetic nephropathy. So we have the ACEs and the ARBs, and they're very effective. And even more effective, in my opinion, are the SGLT2 inhibitors. And we have 2 in the United States, dapagliflozin and canagliflozin, which are already FDA approved, and I will come back to these. We now have the mineralocorticoid receptors, and we have phenytoin in the Fidelity study, which I'm going to review with you briefly. And there's also a suggestion that the GLP-1 receptor agonist will work. So we potentially will have 4 drugs that we can use in combination to help slow the progressive nature of diabetic kidney disease. Now, you've heard from both presenters about the cardiovascular outcome trials. There really are 3 big ones, EMPA-REG, CANVAS, and DECLARE, in terms of prevention of the MACE endpoint. Now, in all of these studies, there was a secondary composite renal outcome, which was worsening renal function, end-stage renal disease, meaning dialysis, transplantation, or renal death. So let's just take a look at these 3 big studies. Let's start here now at the top. Now, in 3 of the studies, there were patients who were admitted who had a previous cardiovascular event. In EMPA-REG, of course, everybody had a cardiovascular event. CANVAS, 2/3 of the people had a cardiovascular event. DECLARE, 1/3 of the people had a cardiovascular event. If we now go over to the right, you see all of the points with the hazard ratio to the left of 1. And 0.54, 0.59, 0.55, mean value 0.56, meaning there's a 44% reduction in this composite renal outcome. Now, in 2 of these studies, CANVAS and DECLARE, as I said, EMPA-REG, everybody had a cardiovascular event to get in. But in CANVAS and DECLARE, these people got in because they had risk factors. And again, you see all of the points lying to the left of the identity line, and the mean hazard ratio 0.54. So quite dramatic effects to decrease this composite renal outcome. But in these cardiovascular outcome trials, the renal composite outcome was a secondary endpoint, and secondary endpoints are not approved by the FDA. So the CREDENCE study was the first dedicated renal outcome study, 4,400 individuals. You could get in either because you had a low GFR or macroproteinuria, and the primary composite outcome was end-stage kidney disease, dialysis, transplantation, doubling of your serum creatinine, renal or cardiovascular death. So what happened? Okay, you can see the placebo yellow curve and the canagliflozin, the orange curve, start to separate at 12 months, and they separate progressively thereafter. Very impressive reduction in the composite renal outcome in cardiovascular events. Hazard ratio is 0.70, lots of zeros on the p-value. So this is a combination, remember, of both renal and cardiovascular outcomes. So let's now take a look at this composite primary outcome. I showed you in all patients, the hazard ratio is 0.70. But let's stratify it now by GFR, 30 to 45, 45 to 60, 60 to 90. Across all levels, you are getting benefit. Now, as I said, this composite outcome was both renal and cardiovascular. So let's just focus on the renal specific outcome. Hazard ratio is 0.66, a 34% reduction. And then if you go across and you look at GFR 30 to 45, 45, 60, 60 to 90, benefit across the board. Now, I told you that there was a second study, and that is shown here, DAPA-CKD, and I've added it in parallel to the Credence study. And look how similar these studies are. Again, you see separation of the curves in DAPA-CKD. At 12 months, they separate progressively. Even more impressive hazard ratio, 0.56, highly statistically significant. So what has DAPA-CKD added to our knowledge? It has told us that the drug works in diabetics as well as non-diabetics. So 55% of the people here in DAPA-CKD had non-diabetic causes of their renal disease. Now, the lower GFR in Credence was 30, 25 in DAPA-CKD, and I'm asked all the time, what should you do if you have someone with the GFR that's lower than 25 to 30? Should you stop the Sglt2 inhibitor? And in fact, that's what the recent KDIGO guidelines suggest. And I have to tell you, I disagree with that. You will see soon papers coming out in Credence. There were about 10% of people who had GFRs below 30, and the same with DAPA-CKD. And those people with very low GFRs benefited as much as the people with GFRs above 25 to 30. So in my opinion, you should be on the Sglt2 inhibitor until the day you walk into the dialysis unit. And of course, once you start dialysis, there's no need to continue on the drug. Well, here now is the third potential drug that we will be able to add to our armamentarium to prevent diabetic nephropathy, and that's feninerone from the Fidelio study. This is Dr. Backrus's study, just recently published in the New England Journal of Medicine. To the left is the renal composite outcome. You can see the hazard ratio is 0.82. Again, curves starting to separate about a year and a half. Now, as a secondary outcome in Fidelio, there was a cardiovascular outcome. Hazard ratio for this composite cardiovascular outcome, 0.76. So now we have a drug, just like the Sglt2 inhibitors, that's giving you renal protection and cardiovascular protection. And as I told you, renal and cardiovascular disease go hand in hand, and we need to treat both. No good to have the patient on dialysis and then have a heart attack, okay? Both issues need to be addressed. Now, what about Sglt2 inhibitors in cardiovascular disease? Both Professor Rosenstock and Del Prado took you through these studies in great detail. I'm just going to use one slide to summarize all of this in a second. But I want to take you back to that earliest slide. Over 1 million people in this healthcare system, in which we looked at the relationship between GFR to the left, greater than 60, to the right, less than 15. And we look at the incidence of cardiovascular events, number per 100 patient years. You see GFR above 6, 2. GFR less than, above 60, 2. Less than 15, 36. If you want to stratify this on the basis of proteinuria, same sort of thing. This is time on the x-axis, months, percentage of people without a cardiovascular event. This should be without, put an out here if you're listening in. If you have low levels of protein excretion, only 10% of your people have had an event, 90% are without a cardiovascular event. If you have protein excretion above 300, you can see 40% of your people have had an event, only 60% without. So whether you look at GFR or protein excretion, you're in trouble in terms of cardiovascular disease if you got kidney disease. So let's now look at these cardiovascular outcomes. As you know, there were 3 trials. The EMPA-REG is going to be shown here in purple, DECLARE in yellow, and CANVAS in green. And if we look at the MACE outpoint, major adverse cardiovascular events, remember, non-fatal MI, non-fatal stroke, cardiovascular mortality, all points to the left. Now, if you look at cardiovascular death, you may think there's some differences here, but look at Empereg, this huge decrease in the hazard ratio to 0.6. Okay, Declare almost no benefit. So why is this? Are these drugs intrinsically different? In my opinion, no. These differences in terms of mortality are more related to the patient population. So in Empereg, 100% of the people got in because they had a cardiovascular event. So of course, where would you expect to see the biggest impact? Decrease in cardiovascular events. In Declare, 2/3 of the people had risk factors. Only 1/3 had an event. So there you see the least impact on death, and Canvas in between. Non-fatal MI, you can see all three very similar. If you look at non-fatal stroke, no benefit from any of the three. That was very surprising to us. Why? Because as both Julio and Stefano pointed out, these SGLT2 inhibitors drop your blood pressure, 5 systolic, 1 to 2 diastolic. And hypertension is a major risk factor for cardiovascular disease. So we would have expected a decrease in stroke, but in fact, we don't see it. And to this day, we're all perplexed. We don't understand this. Hospitalization for heart failure, hazard ratio is 0.7, and kidney disease, hazard ratio is down to about 0.5. So huge benefit in terms of hospitalization for heart failure, and even more benefit in terms of the renal composite outcome. So SGLT2 inhibitors really are cardiorenal metabolic drugs. Cardiac standpoint, they stop MIs, okay? You don't die. Renal standpoint, they protect your kidney. Metabolic, they lower your A1C. You lose weight. We also don't get hypoglycemia with these drugs. They're incredibly safe. So who should be using these drugs as first line? And I agree very strongly with Julio and also with Stefano that these SGLT2 inhibitors should be first line. If you've got a kidney problem, you should be started on metformin. You should be started on an SGLT2 inhibitor. And I would say the same for heart failure or if you've had a cardiovascular event. So who should be using these drugs? Everybody. Primary care physicians, internal medicine doctors. These are your drugs. Endocrinologists, they're your drugs. Cardiologists and nephrologists. Just remember, these drugs cannot cause hypoglycemia. When the glucose, if I were to give an SGLT2 inhibitor to any of you listening in who are non-diabetic, your fasting glucose is 80. What happens to your glucose? Nothing. Yeah, you put a lot of glucose out in the urine, but as much glucose that comes out in the urine, your liver, we've shown this, immediately turns on and makes an amount of glucose that's identical to what's coming out in the urine. You cannot make a person hypoglycemic. Now, if the diabetics on sulfonylureas, well, first, shame on you for using the sulfonylurea, but you can get hypoglycemia, or if they're on insulin. But on the other drugs, you can't get hypoglycemia. So these drugs should be used, they should be used early as first-line therapy, and you can use them in combination with any other drugs. Professor Rosenstock, he likes metformin along with the SGLT2 inhibitors. That's a good combination. I would take it a step further. I would go with triple therapy with either a GLP-1 receptor agonist or pioglitazone. So at this point, I'm going to stop and turn it over to our moderator, and we'll have some time for questions from the audience.
Thank you so much, Professor. So we've had Professor Del Prato answering a few questions for us, in the chat, and we have shared those answers with the audience as well. But we would really appreciate a couple of more questions, maybe, a small discussion. The first question that I would like to share with the panel is, according to you, is there any role to the use of SGLT2 in heart failure patients without diabetes mellitus?
Julio, why don't you answer that?
Yeah, well, of course. I mean, that is exactly the beauty of the two studies. DAPA heart failure had patients with and without diabetes. And so was Emperor reduced. They have with and without heart failure. So now the associations, the Cardiology Association, American Cardiology College of Cardiology, and so on, are recommending the use of Sglt2 inhibitors for HFrEF, which is people with reduced ejection fraction. There is no evidence for people with preserved ejection fraction, except for sotagliflozin, the recent study that they have a combination of the two. It is unclear whether or not that they have what is the component of preserved ejection fraction, but yes, it can be used in people without. It all obviously it all depends whether or not any of your countries in Asia Pacific have this approval or not. But if there's not approval, I mean, with the consent of the patient and the knowledge of the pros and cons, people can use it off-label. But it does work in people without the type 2 diabetes.
Thank you so much, Professor. I have a similar question here, which I know again has already been, discussed in the chat before, in your talk before. One Dr. Anis asks, can I use SGLT2 inhibitors for pre-diabetic patients? Would you like to add something to this question once again?
Well, for prediabetes, there really are no prospective studies for preventing prediabetes going on to diabetes. But in DAPA heart failure, there was a subgroup analysis. And now these are people with reduced ejection fraction. In this subgroup analysis by Dr. Silvio Inzucci, they showed a significant reduction, about a 20% reduction in the emergence of type 2 diabetes in that group. We currently have an NIH grant that's funded to look specifically at the effect of SGLT2 inhibitors and prevention of prediabetes going to diabetes, but that grant is ongoing. And currently, there really is no formally approved drug for preventing prediabetes from going to diabetes. The American Diabetes Association says if you are going to consider such a treatment, they recommend metformin. But we have much stronger data with pioglitazone and much stronger data in the scale studies with GLP-1 receptor agonist. I think eventually we will get data with DPP-4 inhibitors, but I would say at this time we're at a very early stage.
Can I add a comment on that, Ralph?
No.
I think that everyone is very much interested in pre-diabetic subjects. However, I think that Julio, you, and myself have been really advocating early use of SGLT2 in combination with metformin, in combination maybe with other drugs. And I think, people sometimes start focusing too much on people with pre-diabetes and forget that people with a fasting plasma glucose of 126 milligram per deciliter is a complete diabetic person, which is totally entitled to be treated in the proper manner. So I would really not, this is a very important question, but I would really like to invite everybody to consider to start at least to treat properly and intensively people at the beginning of their disease when diabetes is diagnosed. And remember that the diagnosis is not high A1C, is not, being glycosuric or and so on. But and what has been shown also in this discussion is that there is a lot of benefit that can be driven and derived from early combination therapy.
I think Stefano makes a very good point. The pathophysiology, we've shown this. If you're pre-diabetic, it's the same pathophysiology if you're diabetic. Now, if your A1C is 6.4, you're pre-diabetic. If your A1C is 6.5, you're diabetic. So understanding, would you treat 6.5 any differently from 6.4? So to me, this is a little bit sort of an inane discussion. There is a lot of controversy, of course, as to whether you should treat prediabetes or not. But I think Stefano's point needs to be well taken. You need to start early and you need to be aggressive in the treatment.
I mean, there's no question. Any A1C above 6% is abnormal. I mean, in any A1C above 6%. And now we have drugs that we can get you there. I mean, before we could not get there because you have hypoglycemia. You have the early combination of SGLT2. I mean, these people are overweight. These people have risk factors. We've seen the data prevention. I don't know what is holding us back. It is so obvious. And also, I totally concur with Professor DeFronzo. The ADA has been awfully conservative, awfully conservative. I think that this thing about sequential therapy should be a thing of the past. We need to aim for simultaneous therapy with combination therapy. Metformin, SGLT2, you need to hit diabetes hard right from the beginning. And even I may even agree with DeFronzo with his
Oh my God.
love to high, but will not give more than 15 milligrams. I mean, 15 milligrams probably is pretty benign. 30 milligrams, there's a different story, but 15 milligrams, very inexpensive. So it will be a great combination. And the GLP-1, but anything above 6% is a
Julio, we are having problem with people starting with 2. Let's at least start with 2, and then we'll move on to the 3. Okay?
I agree. But you see, I mean, the Francis just got
not the Ralph is wrong. Ralph is always right. But we need to really translate what we have been learning into the daily clinical practice. And you can see the incredible resistance to combination therapy, whatever you can consider as a combination therapy. So we really need to hammer in. I think that combination therapy at the beginning can really provide much more benefit.
There's an interesting question.
And I said combination therapy without specifying how many drugs in the combination. Okay.
Thank you, Stan.
I think that you see, that's the problem. If we are so politically correct without specifying and giving people too many options, people ain't going to do it. I mean, sometimes too many options is not good. I mean, we need to be a little bit more prescriptive. Metformin and SGLT2 ain't going to give you hypoglycemia, and it's going to give you weight loss. It's going to prevent things. And most of the cardiovascular outcome trials have metformin on board. I don't believe that metformin in and itself is going to give you cardiovascular protection, but it won't hurt you. It costs so little that,
We concur. I would just add the third drug.
Yeah, okay. Well, I mean, in India, actually, they have the multi-pill. I mean, they are with three things. So I mean, I won't be if you can put everything in one tablet, that would be help adherence and treatment.
We have Trijardi here in the United States, the Boehringer Ingelheim drug, and it's interesting that it really hasn't caught on, in large part because they really haven't marketed it. But we do have metformin, we have empagliflozin, and we have linagliptin in one tablet. And quite frankly, even though I prefer GLP-1 receptor agonist, I actually think that would be a very good combination. One tablet makes compliance easy.
And I'm not sure if it's in one tablet as opposed to one package. I don't know if it's combined. But anyway, India is very good in the polypill. I mean, that thing is. There's a question there that maybe Professor DeFronzo wants to address. A question I'm reading is: if a patient is starting on SGLT2 that is greater than 30 and the eGFR drops to less than 30, should you continue? And I know your answer.
The answer is absolutely yes. So as a rough rule, what we say is when you put people on an SGLT2 inhibitor, there will be a little bit of drop in the GFR, a little bit of bump in the creatinine. Actually, that's very good. You want that to happen because that says you decreased intraglomerular pressure. And the rule, the cut that we use, and this is now pretty well established, is 30%. So if your creatinine doesn't rise by more than 30%, or the GFR drop by more than 30%, just continue on. If you do drop the GFR by more than 30%, we recommend that you look for other causes. Is there some other cause of the renal disease? Is the patient intravascularly volume depleted? Are they on a non-steroidal? And then if they are, correct those problems and then repeat the serum creatinine. So 30% rule is the one that we go by in terms of the drop in GFR or the increase in serum creatinine. And if you don't get that, you're quite safe and continue on.
Great, Professor. Thank you. I do have my eye on the clock, and if you permit, I'll share one last question with the panel.
Sure.
Go.
Thank you. So I have one question from Dr. Chabra here, where he asks, post an MI with reduced ejection fraction, what duration of time is safe to start with SGLT2 inhibitor therapy?
Say it again. Can you repeat the question?
After how many days of an MI with reduced ejection fraction should SGLT2 inhibitor therapy be started in a patient?
Well, none of us are cardiologists, and maybe our cardiologists will be obvious. The good thing is that we have to be a little bit careful with the SGLT2s. You don't want to give an SGLT2 to somebody who is sick or who is having a prolonged fasting and so on. But if the patient is stable, it can be started anytime. In fact, one of the sotagliflozin studies was done in people who were in the hospital with heart failure there, and so started very early. And so I think that the cardiologists are feeling a little bit more confident on that. As long as the patient is stable, as long as the patient is well hydrated, as well as the patient is not, then I think that the cardiologists are feeling more confident getting those patients. Careful a little bit if the patient is with strong dosages of furosemide, because you may get a hypotensive episode. But apart from that, that's beyond us. I mean, we're just simple diabetologists. Maybe, the FRONZO is a nephrologist and diabetologist. We are just simple diabetologists.
No, what Julio said is correct. Once the patient is stable, either in the hospital or after discharge, you can start the SGLT2 inhibitor. And I just want to point out that in the DAPA heart failure, the longer you waited to start the SGLT2 inhibitor, the less likely you are to get benefit. So the greatest benefit was in year 1. You got very good benefit in year 2. But if you waited 3 years to start the SGLT2 inhibitor, all the benefit was completely lost. So as soon as you stabilize the patient, I think you should go ahead and start the patient. And if they had an MI, then I think the interesting question is, would you start, and there's no answer to this, a GLP-1 receptor agonist along with an SGLT2 inhibitor, because both have been shown to decrease cardiovascular events. And hopefully someday someone will do this combination study, although most companies don't have both drugs, so they're not anxious to do the combination study. Maybe the NIH will do it.
And by the way, the DICTATE trial is ongoing, just looking at the people with acute heart failure. Treated with dapagliflozin.
Yeah.
With that last question, thank you so much, professors, for your time, for your candid insights into the topic. Much appreciated. It's an honor to have you on the panel today. And I'm sure our audience is also delighted. We have had a huge, long list of messages only as appreciation, and thank you for this panel. While I thank the panel, I would also like to take this opportunity and thank the audience who's joined us today and for their active participation. We've had an audience of, from over 32 countries joining this session right now. So thank you so much. And once again, thank you so much to the panel. Thank you so much, professors. It was an honor to host this session for you this evening.
Thank you very much.
Okay, thanks. Good to see you, Julio.
Good to see you, Rob. Bye, Stefano. Ciao.